Good morning, everyone. My topic for today is diabetes mellitus in elderly with special focus on frailty and sarcopenia. So, introduction. Global burden. Diabetes affects approximately 828 million adults worldwide with a proportion of around 14%. Adults aged 65 years and above are highest prevalence, significantly more than the younger age groups. With increasing age, insulin production declines and resistance increases, influenced by obesity and muscle loss. Diabetes contributes to reduced muscle mass, strength, and function, leading to sarcopenia, frailty, and disability. Frailty often results from sarcopenia, which is marked by poor physical performance but is potentially reversible. India is the second largest elderly population facing unique critical and healthcare challenges. Early detection and intervention frailty are crucial, yet studies in the Indian population regarding this are very limited. So, materials and methods. This research was carried out in the medicine department at Kasturba Medical College, located in Manipal. Sample size was 160. This was a cross-sectional study and hospital-based. Patients' data was collected prospectively over the period of 22 months, July 2023 to April 2025. This was done after obtaining permission from Institutional Ethics Committee. Criteria selected was elderly individuals above the age of 60 with diabetes mellitus attending the OPD as well as inpatients in Kasturba Hospital, Manipal. I have excluded patients with stroke, malignancy, tuberculosis, hyperthyroidism, physically inactive or bedridden patients, those on steroid treatment or neurodegenerative disorders or who are malnourished. So my primary objectives were to evaluate elderly diabetes individuals for clinical features and complications to assess frailty by frailty score. Edmonton frailty score I have selected for this, and to evaluate sarcopenia risk by SARC-F questionnaire. My secondary objective was to correlate frailty and sarcopenia with glycemic control. Coming to results, most of my population was between 60 to 70 years of age group, 55.6% in that, and 38.1% were in 71 to 80 age group, predominantly males, which comprise 63.1%. Body mass index, this was based on Asian classification. Majority of them were in obese class 1, 41.3%. So this was between 25 to 29.9. Most of them came for follow-up on OPD, so most of them were asymptomatic on presentation. The most common clinical presentation in few members were fatigue, which was 10.6%. Others experienced polyuria, polydipsia, vomiting, burning micturition. Most common comorbidity associated with diabetes in my study population was hypertension, which was 78.1%, followed by dyslipidemia and ischemic heart disease. Most common complication was cardiovascular diseases, around 28.1, which is followed by diabetic neuropathy and nephropathy. So, most of them were on oral hypoglycemic agents, approximately 79.4%. 17.5% were on both oral hypoglycemic agents as well as insulin. And there was very good drug compliance, 96.3% had good compliance. And majority of them were on metformin, sulfonylureas and DPP-4. Sulfonylureas compromised around 61.3% here. And EFS severity wise, most 20.6% were in the vulnerable group or pre-frail group, whereas frailty was seen in 14.4%, with mild frailty seen in 9.4%. Sarcopenia risk was present in 36.9% of the individuals. Also, hypoglycemic episodes were seen in 11.2% of the individuals. And coming to correlation, strong positive correlation was seen between EFS and SARC-F, but however there is no significant correlation between HbA1c and EFS or SARC-F. This is the correlation graph which is showing significant positive correlation with EF and SARC-F, but no significant correlation with HbA1c, EF and SARC-F. So this is so discussion. My majority of the age group was between the 61 to 70 age group, mainly male predominance, which is similar to Coleridge et al. And my study at lower complication rates of neuropathy and nephropathy, which was 15%, 11.9%, compared to Coleridge et al. Study, which showed neuropathy was 43.5% and nephropathy was 29.6%, probably due to better glycemic control and hospital-based monitoring was there here. And frailty proportion in our study, it was observed that there was 14.4% frailty with 20.6 being pre-fail. This is lower than the Western data which was done in Manja et al., which was showing 67%. But there was one systematic review which was done by Singhal et al., which was showing frailty of 42.3% in India as well, but in Karnataka specific it was 28.48%. But the parameters used for frailty was different. I have used Edmonton frailty scale here. Sarcopenia proportion risk is 36.9%, which is higher than the Asian meta-analysis, which was 15.9%. There was one CMC Vellore study, which was done by Raymond et al., which was showing 39.2%. This similarity could be due to the similar age groups and screening tools which we have used. Coming to correlation between EFS, SARC-F and HbA1c. So unlike Alfredo Alvarado, we did not find any direct link between HbA1c and frailty. However, there is one study, Mangaloore et al., which noted that HbA1c and EFS may not be significant correlation because both low and high HbA1c may lead to frailty, because hypoglycemia is also one of the factors which may cause frailty. Coming to sarcopenia frailty link, strong correlation was seen between SARC-F and EF, highlighting the interconnected nature of muscle loss and frailty in elderly diabetes. Coming to summary, frailty was seen in 14.4% of my study population, 20.6% of those who were pre-frail or vulnerable group. Sarcopenia risk is identified in 36.9% of the study population. So this population is the one which could be targeted for treatment like resistance exercises. Fatigue was the most common clinical presentation in my study, almost 10.6, and cardiovascular disease was the most common complication affecting 28.1%. There was negligible correlation between frailty, sarcopenia, and HbA1c. However, a strong correlation was seen between sarcopenia and frailty. A limitation in my study was this is just a cross-section study, and over a period of time, how frailty and sarcopenia is evolving with glycemic control, we could not study. And also, since this is just an hospital-based study, we cannot generalize to community. So that was two limitations. Thank you, sir.
Is there any other significant factor because of which you are not finding any correlation with HbA1c and sarcopenia here?
One more confounding factor could be BMI, sir.
Switch off the phone.
One more confounding factor could be BMI, sir, like obesity and insulin resistance is also one of the factors which could lead to frailty and sarcopenia.
In practice, how will you assess sarcopenia? One problem I will say is the questionnaire-based sarcopenia assessment. How will you assess sarcopenia in practice, clinical practice?
Actually, clinical practice for diagnostic criteria, there is a different diagnostic criteria, so gait speed, gait strength and lean body mass measurement. But what I have done is I have assessed SARC-F questionnaire, which is actually sarcopenia risk, not clinically we use it by gait speed, gait strength and lean body mass measurements.
What's the gold standard test to assess sarcopenia?
Measurement of lean body mass.
No, what is the gold standard test to assess sarcopenia in research? If you're practicing a research and you want to document sarcopenia in your patient, what is the gold standard test?
Not as.
Yeah, I think one question is already done. So, when you screen someone with SARC-F questionnaire,
Yes, sir.
does it establish a diagnosis of sarcopenia?
No, sir, it does not establish.
So it's usually screened for sarcopenia.
It's just a screen, just a sarcopenia risk, sir. For diagnosis, we need the diagnostic criteria.
Yeah, so just like Pradosh has asked, there are simple things which you could do in the outpatient which would add more value to your
Yes,
data
sir.
which
Yeah.
is there.
Yeah.
Second is, I saw that your inclusion criteria includes both inpatient and outpatient.
Outpatient also, sir.
So, do you think that being an inpatient itself for a short while would change their status in terms of sarcopenia?
Yes, sir, it could be. But I have only included those who are admitted for uncontrolled sugars for insulin control. Only those people I have included, sir. Only.
And again, are these consecutive patients? Because I see you have done it over a period of 3 years. And
No,
you
sir,
could
this
get
is not
only-
consecutive. This is not.
So anyone who is giving an informed consent, you take them.
Yes, sir. Yes.
So there's a good selection bias which would come in that area because you're not consecutively recruiting patients into
No,
this.
no, not consecutively.
Fine, I think then frailty, all those things, okay, fine. And I think and next time when you plan it, you should probably look at more factors other than the glycemic control which would affect
Yes,
such a common condition, and probably
Yes,
a bigger number of patients would
Yes, sir.
help, definitely.
I think one of my questions has already been asked because questionnaire-based assessment of sarcopenia is something which now we have methods to, check the muscle and the lean body mass.
Lean body mass.
Now, other factors which are very important would be physical activity.
Yes, sir.
Most of the elderly patients are very active. So has that been looked at?
Yes, ma'am. In the Edmonton frailty scoring, and it is mentioned, ma'am, physical activity. Based on that, we are scoring.
What type of physical activity they do and how long and
Uh,
duration?
whether they are able to go out for shopping, meal. They have included like cognitive testing. One is, which is with clock test is included. One is 100-meter test is included, ma'am. One more, whether they are able to lift 10 pounds weight, whether they are able to climb flight of 10 stairs. These things are included, ma'am.
And many of these patients had chronic renal disease also.
Yeah, chronic kidney
Which
disease
can be
also.
a very strong confounding factor.
Could be, ma'am. We also included because it also could be a potential complication of diabetes
So what is
itself.
the takeaway from your so-called questionnaire-based assessment?
Ma'am,
What is your takeaway from this study that you have done?
my takeaway would be like I need to correlate with more factors which could, and probably I should have included BMI as well as probably other cofactors which could cause frailty and sarcopenia. I've only included like glycemic control, so there may be multi factors which I should have included in this study.